Challenges and solutions for through-the-channel deflecting grasper-assisted retraction during ESD. This was an investigator-initiated and designed study. The Fujifilm Corporation provided no financial support but did supply the track motion grasper and other disposable equipment needed for ESD, as well as a loaner endoscopic tower and endoscope for the study. This study was made possible by support to the Northwell Advanced Endoscopy Laboratory provided by the Northwell Health Department of Surgery, the Thompson Family Foundation, Lawrence Silvestro, and other grateful patients. Endoscopic submucosal dissection, or ESD, is the gold standard method for the removal of large sessile polyps. ESD allows for en bloc removal, which permits pathologic evaluation of the deep and lateral margins. Versus EMR, recurrence rates are also lower. In ESD, after expansion of the submucosal layer with an injection, the mucosa is incised and the polyp submucosal attachments systematically detached. Snare polypectomy, in which the polyp is rapidly garroted in seconds. In ESD, the polyp is systematically detached, which takes time and requires fine control over the needle knife, which protrudes from the moving scope tip. Because ESD is essentially a surgical procedure, obtaining exposure and retraction are critical. The only means of retraction in ESD are gravity, under certain conditions, and the dissection cap, which is attached to the scope's tip. Provided the patient is positioned so that the polyp is up, later in the case, after detaching a good portion, the polyp hangs down, which provides some traction and facilitates removal. A clear plastic dissection cap is placed on the scope's end so that the edge extends 5 to 7 millimeters beyond the tip. Once a mucosal incision has been made and the polyp undermined a bit, the cut edge can be retracted with the cap tip by deflecting the scope tip. This places the submucosal fibers on stretch and presents them to the knife. When enough submucosa has been divided and the entire scope tip can be placed in the bowel wall, pushing or torquing the scope in the pocket stretches and exposes the remaining attachments. Despite these methods, much of an ESD case is done without active retraction, which increases the difficulty considerably. A number of retraction solutions have been developed. Both the Orice TRS and the second-generation Lumendi overtube systems create working spaces and are also capable of retracting tissue via independent graspers. Transanal robotic endoscopic platforms with multiple arms have also been designed and used in a limited manner. These platforms have not been widely adopted because one product was taken off the market and the other two are expensive and have substantial learning curves. Also, it is not clear when to use these tools. It is possible to retract tissue with a double-channel scope with a grasper placed in the second channel. Once the edge is grasped, the scope tip can be deflected upward, which retracts the wall. Unfortunately, because the graspers are straight, upward deflection also shifts the scope's view up and away from the dissection field. Thus, exposure is provided, but it cannot be utilized because the scope is looking at the retracted edge and not the submucosa. For a double-channel scope, what is needed is a stable grasper that bends and can be torqued left or right. In this way, retraction is obtained while maintaining a view of the submucosal dissection field. The grasper system fits this description and is an option for rectal and sigmoid polyps, provided a double-channel upper endoscope is used. The grasper shaft near the tip is straight when open. However, when the grasper handle is closed, the instrument bends 90 degrees, about 1.5 to 1.8 centimeters from the tip. The grasper handle locks onto a mount placed on the scope. The direction of tissue retraction can be finely controlled by twisting the closed handle. The position of the grasp flap is stable once the device is closed and positioned. Prior to using the grasper, standard ESD methods must be used to incise the mucosa circumferentially. A submucosal lift must be established first. Here, a sclerotherapy needle was used. After mucosal incision, the proximal half of the polyp should also be undermined for a short distance. A standard dissection cap is being used to retract the cut edge in places. Also, the distal 2 to 3 centimeters of the polyp must be detached in the submucosal plane. The distal polyp flap must be fairly long for the grasper to be useful. To reiterate, before inserting the grasper, there must be a lengthy distal flap. Once the grasper is in the colon, the distal edge of the polyp pelt is grasped and lifted. Ideally, this will provide the desired exposure. Importantly, when using the track motion grasper, the direction of dissection must be distal to proximal. It is important to note that once the distal flap has been retracted, view of the proximal part of the polyp is blocked. This is why full circumferential scoring and some undermining is recommended before the grasper is used. If the distal part of the polyp is not adequately detached prior to grasper use, retraction will lift the muscularis propria layer into the needle knife's dissection field. Use of the needle knife in this situation may injure or perforate the deep bowel wall. If the flap is sufficiently long enough, grasper retraction exposes the submucosal fibers to be cut. Ideally, flap retraction presents the stretched submucosal fibers to the needle knife, which are then cut. The retraction obtained is clearly superior to the exposure seen during standard ESD. It is important to note that the scope tip is further away from the dissection field when compared to standard ESD. This provides a much broader view of the polyp and bowel wall, which better orients the endoscopist. It also allows longer cutting strokes, which shorten the case. Adjusting the torque on the retractor handle changes the retraction and allows more of the polyp to be detached. Usually the grasping point needs to be changed several times in order to expose different aspects of the polyp's attachments. Although the lift is not as crucial when active retraction is present, it is advised that the lift be refreshed periodically since it expands the dissection field and can also clarify the location of the deep muscle layer. If a needle knife with injection capability is used, the lift can be refreshed without withdrawing the knife. With retraction, steady progress can be made and the case completed in notably less time than a standard ESD. There are some key characteristics of the track motion system that need to be understood. First, fully closing the handle bends the tip of the grasper 90 degrees. Second, twisting the handle rotates the grasped tissue in a one-to-one manner, which alters the exposure. Third, the grasper, once employed, can be withdrawn a short distance. Fourth, the handle and grasper will maintain their position without being held. And finally, the endoscopist fully controls the grasper. It is highly unlikely that the distal flap mobilization done prior to grasper use will be ideal. There are numerous ways to alter exposure with the track motion system. First, a smaller bite of the flap can be grasped. This adds length to the flap. Secondly, with a grasp in place, opening the handle a bit will decrease the deflection angle, which lowers the flap. Thirdly, by rotating the fully closed handle, the height and focus of the retraction changes. Fourthly, with the grasper in stable position, pulling the scope backwards will alter the intersection point of the knife tip and bowel wall. Lastly, the grasper can be withdrawn from the scope mount, which will shorten the distance between scope and grasper. The goal is to put the knife in position to cut submucosal fibers. Partially opening the grasper handle decreases the angle of retraction, which decreases the retraction height. If a short flap is present, then this maneuver may lower the submucosal layer into the knife's operative field. Another way to alter the retraction is to rotate the closed grasper. Maximal retraction occurs when the bent grasper is directed vertically into the center of the bowel. Rotating to the left will decrease flap elevation, but will increase traction on the right side of the polyp. Therefore, when the exposure is not ideal, the handle should be rotated in both directions in an effort to improve access to the submucosal layer. If the retraction is exposing the submucosa but the knife is too high on the flap, then pulling the scope backwards while further inserting the grasper and the knife will tend to lower the knife's intersection point with the flap and may permit detachment. The lift is less critical once good retraction has been established since the submucosal layer is being stretched. Nonetheless, it is still recommended that the lift be refreshed periodically because it expands the submucosal layer, which is the target. It also better defines the muscle-submucosal interface and decreases the risk of perforation. To summarize, a controllable bendable grasper can be used to facilitate the latter 1/2 to 2/3 of ESD cases done in the rectum or sigmoid colon with a double-channel upper endoscope. A small ex vivo study showed a 7-minute time savings with the grasper. It is important to note that there is a clear learning curve that must be completed and that the method of detachment is different than for standard ESD. There are many grasper-related variables that impact the exposure obtained. It is advised that trainees do some cases in ex vivo porcine or bovine colon prior to doing clinical cases. It is the opinion of the investigators that this method has great potential and merits further study and use.